Yes.
Recording in progress.
Repeat. 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 There we go. Good afternoon, ladies and gentlemen. Can you hear me, Percy?
Yes, I can.
Okay. Well, a great big welcome to all the people that have logged on this afternoon. We have, as can be seen over there, our guest speaker, Dr. Sundra Prakasan Percy Moodley. Now, he's certainly no stranger. He's been on this platform before, and it's wonderful to have him over here. And Sundra Prakasan, welcome from Durban. I'm sure it's a lot warmer there and better there than in Cape Town, which is cold, wet, and windy. We also have Wendy over here, and of course, Nadir. And in a minute or two, we will have our indefatigable president, Professor Steve Jeffries. It's wonderful to have Percy Moodley with us this afternoon. He's speaking about clinical guidelines. He's the immediate past president of the South African Menopause Society. Now, last week, those of you that were on the Zoom and would have heard me make a big blunder, I said that he was the president of the South African Menopause Society. Of course, we all know Sam's president at the moment is Dr. Malika van der Schuyf. It's great to have you with us, and it's even nicer to have Abbott sponsoring us this afternoon, Percy. So just before I begin, I'd just like to remind you all that at the end of this month, of course, is SASOG. And will you be going up to SASOG, Percy?
No, not this year. My colleagues are going up this year.
Okay, you're posting your colleagues up. Well, I will be at SASOG end of this month, and I hope to see many of our friends from the Pelvic Floor Foundation of South Africa there. So, Percy, without further waste of time, I'd like to thank you for being here this afternoon, and we look forward to, with great trepidation, hormone therapy clinical guidelines presented the night before on the eve of this very special Women's Day evening. So, Percy Moodley, for the occasion of Women's Day, hormone therapy clinical guidelines. Thank you very much.
Sorry, Doctor, I just need to play Abbott's video for us quickly.
Okay.
Thank you.
June had always led an active life, but when she reached menopause, her symptoms caused her to feel isolated, affecting her work and home life. Medical societies recommend menopausal hormone therapy as effective or the most effective treatment for menopause symptoms. But not all MHTs are the same. In women taking estradiol and dydrogesterone, the ingredients found exclusively in Femiston, there is a lower risk of breast cancer compared with other combined MHT. And the risk of venous thromboembolism is lower than in users of other oral preparations, such as norpregnane-type progestogens, or no MHT. With proven benefits for a range of menopausal symptoms, Femiston can help June take back control of her life. Femiston makes her life better in post-menopause. Femiston is the world's #1 brand for estrogen deficiency in volume.
Right, thank you, Percy. So without further ado, hormonal therapy clinical guidelines. Over to you. You can share your slides.
Let's just change it here. Hi, good evening. It is a real privilege for me, and thanks to the Pelvic Floor Foundation to ask me to present this talk. And today I was just going to do the clinical guidelines of hormone therapy. So hopefully these will be just clinical messages for the jobbing doctor out there. I'm not aiming to present lots of studies, but just the messages with each aspect. So there's robust evidence that estrogen is highly effective treatment for hot flushes and for what we call the genitourinary syndrome of menopause. If we use it before the age of 60 or within 10 years of the menopause, it's effective in reducing the death rate, prevents coronary artery disease and hip fractures. But there's been a significant drop in hormone therapy use from 2002 when the WHI, Women's Health Initiative, study results were released. This is based on patient fear, misunderstanding of the risk-benefit ratio, and also lack of appropriate education of providers. So in the past, it was recommended for all women as soon as they reach the menopause and even in the perimenopause. But presently, we use it for only definite indications. And like everything in medicine that we use, we should be always computing the benefit versus the risk, but especially if you're using it as a preventative role. So what are the indications? It's to reduce menopausal symptoms. It's the only recognized treatment of osteopenia. And I must say, I still see a lot of patients with osteopenia that are on anti-osteoporotic drugs already. It's given for the prevention of osteoporosis, for the improvement of sexual function, for the effective treatment of the genitourinary syndrome of menopause, or what in the past we just called dryness of the vagina, and it may reduce the incidence of cardiovascular disease. So there's no talk on hormone therapy that doesn't mention the Women's Health Initiative study. So this was a large randomized controlled study, and I don't think we'll ever be able to repeat a study as big as this. Unfortunately, the average age of the patients in the study was 63 years and almost 12 years past the menopause. And the main reason they chose an older group was the primary study outcome in this trial was that of coronary artery disease. And when the press released on the results of the study in 2002, the preliminary press release, it focused on breast cancer, which heightened the emotion. But it did show that there was an increase in cardiovascular disease in the first year with a decreased trend over time, and an increase in breast cancer beginning at 3 years. So this was a well-designed clinical trial. Unfortunately, it was done in the wrong population, not the type of patient that you and I see in our practice, not the age group that we see that requires, maybe symptomatic and requiring treatment. But it does deserve credit for demonstrating that hormone therapy in older and higher risk women to prevent cardiovascular disease and dementia is not supported by scientific evidence. So you have different formulations. So we'll go a little bit to some basic science here. So if you look at estrogen, you have basically 4 types of estrogen. E1 or estrogen 1 is estrone, which is the primary form of estrogen that your body makes after menopause. And E2 is the major metabolically active estrogen produced by females in the reproductive years. So it is often marketed as a natural hormone or bioidentical to natural estrogen. And in the Women's Health Initiative study, they did not use estradiol. They used conjugated equine estrogens, which you must understand is a mixture of estrogen-like compounds, and some of them have selective estrogen receptor modulator characteristics. It's important to realize that, and I'll allude to that later when I talk about the breast. But in general, your side effects as far as estrogen are concerned are related to the dose of estrogen.
Percy, sorry, Percy. As you said at the beginning, we've got a lot of jobbing gynecologists and women's health practitioners here, and they're asking very practical questions. And the very first practical question for you comes from Moira Stein, which says, women are being told by their doctors that they may only start hormonal therapy after a year of amenorrhea. Is this good or bad advice, is your question?
No, it's definitely not good advice, because there are some patients who will be symptomatic even in the perimenopause. That means they may still be getting their periods, but will have symptoms that may warrant treatment. So you don't have to wait till 1 year after the therapy.
So you can be menopausal and still have symptoms and bleeding as well?
Yes, you can be symptomatic with symptoms of the menopause, yet you may still be having periods.
Okay, thank you.
Sorry,
Sorry,
I've also just joined. We get a lot of.
This is Steve Jeffrey, Professor Jeffrey.
Hi. A lot of patients, Peter, a lot of patients asking you to do bloods first, or I mean,
Yes.
so does it help at all? I mean, do you just start?
A common question: what bloods must I have done before I see you? Because I need to have some therapy. Is this important, or can you go on clinical evidence?
So the clinical definition of menopause is when you don't have menses for 1 year. So if I see a patient who last had a period 18 months ago and she comes in and she gives me complaints of symptoms of the menopause, I do not need to do any blood test to confirm that she's reached the menopause. But if I see patients in the perimenopause who are still getting periods and have some symptoms, then I may need to do hormonal tests. But if you do the hormonal tests, you must do it during the period. So you can't do an estrogen level at any time of the cycle. If you need to do an FSH and E2 level, you need to do it during the period, one of the days that she's having a period. That's the only way that you can really compare it to normal hormones.
Okay, that's good advice. It's very
Thank
good
you.
advice. Thank you.
Okay, so when you come to progestogens, the only naturally occurring progestogen is natural progesterone. And all the other progestogens are synthetically produced, and we call them progestins. And they differ in the following ways: in the way that they stimulate the progestogen receptor. They can be either pro-estrogenic or anti-estrogenic, pro-androgenic or anti-androgenic, and some of them have glucocorticoid activity. So when you look at natural progestogen or natural micronized progestogen, it has a unique pharmacodynamic and safety profile depending on the route of administration. And actually it undergoes a process of micronization, and that allows us to use it clinically. It's now available for us to use it either as a tablet or even as a pessary. So the synthetic analogs of progesterone, which I call progestins, were basically developed to make the hormone available orally. And actually they were first produced to help with contraception. I think this is a very important statement. Small differences in structure among the progestogens will lead to differences in metabolic and pharmacological effects. So this is just takes you back to your basic sciences, shows you the different types of progestogens. So if you look right at the top, you have the natural progestogen, and the next to it is the retroprogestogen, which is dihydrogesterone, and that is very similar in its effects to progesterone. And you get all the other types. So the progestogen, if you take progesterone, which is the natural progesterone, it binds primarily to the progestogen receptors with minimal binding to the other receptors. And dihydrogestogen behaves in a similar manner, whereas medroxyprogestogen acetate, which was used in the WHI study, binds to progesterone receptors and glucocorticoid receptors. So the fact that it binds to glucocorticoid receptors means that it can have certain glucocorticoid effects, some unwanted glucocorticoid effects. And noethistérone, for example, binds to progestogen, estrogen, and androgen receptors. This is just some basic science so that you have some idea when you're prescribing hormone therapy that all hormone therapy is not the same. You've got to understand that there are differences. Then comes to the big talk, which we hear in our rooms all the time. What about natural supplements? So it falls into the category of what we call compounded bioidentical hormones. Now, bioidentical just implies similarity to endogenous hormones, and it includes the government-approved and the compounded therapies. But the compounded therapy suffers from the lack of government regulation. So therefore, you may get inconsistency in the strength of the levels of the hormones because it depends from where you source them. And many of them often lack labels and don't illustrate the risks. Then another thing that I see a lot, not a lot, but fortunately decreasing, but definitely still occurs, patients coming after having lots of salivary and urine hormone testing to determine dosing of the hormones that they require. This is definitely unreliable and not recommended. And coming back to what Prof. Jeffrey asked, serum hormone testing is really needed. I sometimes do it when I have patients on transdermal hormone therapy and they're not showing a response, although I'm increasing it. And occasionally I've found that when I've done the estrogen level in those patients, I've demonstrated low estrogen levels despite high doses of the transdermal, and that means that that patient is not absorbing the transdermal. If you switch that patient to oral therapy, symptoms get relieved. So that's one of the examples in which I sometimes do serum testing. So situations in which compounded bioidentical hormones could be considered occur when ingredients in government-approved products, the patient may be allergic to them, or there may be unavailability. So we're not saying that all compounded products are absolutely useless. There are some times that we have to use them when we do not have government-approved products. So the cardinal symptom of the menopause is hot flushes. So it's important to realize that these vasomotor symptoms may begin during the perimenopause, and they persist on average for about 7 years or longer. Hormone therapy remains the gold standard for the relief of these vasomotor symptoms, and estrogen-only therapy is used if the patient does not have a uterus. If they have a uterus and they're symptomatic, then you have to add a progestogen to prevent endometrial hyperplasia and cancer. Hormone therapy also improves sleep by reducing the nighttime awakenings. And specifically, micronized progesterone can improve sleep as it increases the production of gamma aminobutyric acid. So sometimes if I have a patient where the insomnia is a major component of her symptoms, I will tend to choose a combination that includes micronized progesterone. Vulvovaginal atrophy, which Prof. Jeffrey also discussed last week, is a progressive symptom which is underestimated, underreported, and certainly undertreated. So the International Menopause Society changed the name to genitourinary syndrome of menopause, and the main reason they did it was to emphasize the urinary component of this condition. And the reason they did it is you will see patients sometimes in the 60s and sometimes 70s who tell you that they have received about 4 courses of antibiotics in the last year for urinary tract infection. When you take a history from them, some of them are not sexually active. So the chances of them having a urinary tract infection are very low. And basically what they have is this genitourinary syndrome of menopause. And many of them do not need any of the antibiotics. It's also important to realize that about 1/3 of women will still have this vulvovaginal atrophy, despite you putting on systemic hormone therapy. So the low dose vaginal estrogen preparations are effective, minimal absorption, and you don't need to give them any additional progestogen therapy if you're only using local estrogens. And as I said, a percentage of patients on systemic hormone therapy may require additional vaginal estrogen. The breast cancer survivors are a special lot. They have severe vaginal symptoms, especially related to a lot of the drugs that the oncologists put them on. And local vaginal estrogen therapy can be offered to them after discussion with their attending oncologist. Hormone therapy improves sexuality mainly by its improvement of atrophic vaginitis. So what about the safety of local estrogens? The serum levels are similar in treated and untreated patients at 2 years of assessment, irrespective of the route of which you're using the vaginal estrogens, whether it's estrogen tablets, the vaginal ring, or creams. Okay, we'll now move on to the bone. So in the absence of contraindications in women younger than 60 years of age or within 10 years of the menopause, systemic hormone therapy is appropriate to protect against bone loss. So I basically tell my patients there are 3 main indications to treat you to offer you treatment for menopause. 1 is if they are symptomatic. 2, if they have high risk for bone problems. And 3, for sexuality reasons. So sarcopenia and osteoporosis are related to aging and estrogen depletion, and exercise plus estrogen therapy has the potential to prevent loss of muscle and to improve strength and performance. So the importance of exercise has to be emphasized. What about diabetes?
Sorry, Percy, can I just ask you something related to that slide?
Sure.
Is it just, sometimes you get those patients who come and say, like, it's, they've had menopause quite a while ago and they've never had hormone therapy. There's all these guidelines and concerns about when to starting it quite late. What is your practice as practical point of view in terms of when is the latest you can actually start the hormone therapy?
Yeah, so it's a good question because the ideal time to use it is within the first 10 years of menopause, or if you're needing to use it in patients over the age of 60, you have to have careful consideration because you have to make sure at their general health, because as the WHI study showed, when you use it in the older patients and if they already have established coronary artery disease, etc., you may end up with complications. So the ideal time is to treat them within the first 10 years, especially from a point of view of cardiovascular protection. But as I'll show you in a slide later, that if you have had a delay between your menopause, when your menopause started, which average age is about 51 years, but if you had a delay between when you starting therapy, maybe at 55, 56, those patients who had a gap period between the start of menopause and when they needed to start therapy, that is actually protective as far as the breast is concerned. So you gain by protecting your heart if you start it immediately, if you're symptomatic, but you certainly gain if you start it later as far as the breast protection is concerned. So there's always advantages and disadvantages as to when you needing to use it. But definitely within the first 10 years, no problem. If you're using it over the age of 60, I have, but I've really looked at those patients and counseled them very properly.
Sorry, Percy, did you say when is the best time to stop menopausal therapy is another question, yeah.
Oh, no, yeah. So all the guidelines nowadays do not have a stop date for stopping hormone therapy. But, you know, when you have to make this decision. I mean, I normally see my patients either yearly or once in 2 years. And then I make a decision and they report to me if there's been any change in their health, etc. And then you can make a decision if they want to carry on. When you explain some of the risks of being on hormone therapy later in life, some of them say, can I have a trial without it? Or you decide whether you want to give them a trial. And if they've been off it for 3 or 4 months, some of them will come back and say, no, I can't cope, I'm getting the symptoms. And some of them I will re-put them, I would put them back on therapy. But I've got one slide at the end which shows this.
Thank you.
So about diabetes, it certainly reduces the incidence of type 2 diabetes. It's not contraindicated in anybody who's got diabetes, but diabetes on its own is not an indication to commence hormone therapy. The one disadvantage is the risk of gallstones and cholecystitis is increased with hormone therapy. And that's basically because estrogen causes more cholesterol to be produced, and the progestogen component reduces the motility of the bile duct, and therefore cholecystitis sometimes is found with increased frequency compared to the premenopausal patient. This is a common factor that I'm now seeing, brain fog in the menopause, and this is because women are very active in the workforce and are still functional, still all working at this age, and cognitive complaints are common. And many of these patients who have these learning or recall memory lapses, they have a fear of later life dementia. So I must tell you that these memory difficulties resolve for many women post-menopause, and it's not an indication that they have a higher incidence of Alzheimer's or dementia. Low education and social disparities exacerbate these cognitive vulnerabilities. And obviously, if you treat the vasomotor symptoms, decrease the sleep disturbances, and improve mood, you'll help. But hormone therapy is not recommended as a primary indication for cognitive issues. A lot of the work that was done on this work is by Pauline Mackay and Nicole Jeff, who's a member of our Menopause Society. And in the Climacteric, they have a very good review on this. So coming back to how does one try and prevent this brain deficit? It's a multi-pronged approach. You need to look at all the modifiable risk factors, decrease obesity, treat your hypertension, diabetes, obviously not smoke, treat depression. But the very important, a part that's emphasized a lot is social interaction. And we saw this during the COVID period. When social interaction was minimal, these cognitive issues increased. Okay, so we now move on to cardiovascular disease. And as I said to you, the effect of hormone therapy on coronary artery disease may vary according to when it is initiated in relationship to a lady's age or time since the menopause. And we call this the window of opportunity for treatment. So if you institute treatment in the recently postmenopausal woman or within the first 10 years, this reduces subclinical atherosclerosis progression and coronary artery calcification. Shown in the study that was done by Manson and published in JAMA in 2013, in the 50 to 59 year age group, there was a decrease in heart disease. 60 to 69 years, it almost approached neutrality. And once you were over 70, it crossed the line then. This was a great study called the ELITO, called early or late intervention with estrogen. So if you used it within the first 6 years, it reduced atherosclerosis. When you used it after the patient has been through 10 years of menopause already, it had no effect on the progression of subclinical atherosclerosis. So from a cardiac point of view, cardiac point of view, if you want to use hormone therapy, you need to use it early in the menopause. What about venous thromboembolism? Well, this is elevated in women who use hormone therapy, especially in the first year of treatment. And the risk factors are obesity and older age. So coming back to your question about whether you'll use it in the patient over 60. So this is one of the things you'll have to consider when they above the age of 60 and you want to initiate treatment, because that category, there will be an increased incidence of venous thromboembolism. Lower doses of oral hormone therapy may confer less risk of venous thromboembolism. And micronized progesterone or dihydrogestogen may be less thrombogenic than the other progestogens. And if you got patients who have a higher risk or a slightly above average risk for thromboembolism, then you must consider transdermal hormone therapy in this group category of patients, because in observational studies, they have not been associated with any venous thromboembolic risk. Right, coming to the main thing, breast cancer, which is, I think, dominates all our conversation when we deal with patients in the menopause. So if you look at the perception of causes of death by women, the majority think it's due to breast cancer. And in reality, the majority is due to heart disease. So putting it in another way, when asked to rank health concerns, women and healthcare providers place breast cancer at the top of the list. So that's why this fear of breast cancer dominates our conversation when we counseling patients in the menopause. So this slide summarizes what you need to know about breast cancer. The effect of hormone therapy on breast cancer risk may depend on the type of hormone therapy, the duration of exposure, and individual characteristics. For example, if you do a baseline mammogram and there's increased breast density, that's an independent risk factor for breast cancer. So if you see that in your patients and you wanting to give them hormone therapy, then you must flag that patient and say that I would probably look at discontinuing therapy in that patient beyond 4 to 5 years, because we've realized from studies that the breast cancer risk is only starts to surface after the 4th or 5th year. So there is level 1 evidence that the addition of a progestogen to estrogen as part of menopausal hormone therapy increases the risk of breast cancer. So patients who've had a hysterectomy for any other reason and they reach the menopause and become symptomatic and you only need to give them estrogen therapy, their risk of breast cancer decreases dramatically. There is evidence for preclinical and observational studies that the use of naturalized micronized progesterone or dihydrogestogen with estrogen are a safer option than synthetic progestogens, in that they do not result in an increased risk of breast cancer when used for 5 years, and a much lower risk of breast cancer other than if used beyond 5 years. So up to 5 years, if I see patients who fall into a profile with a higher risk of possible breast cancer, then I would choose in my hormone therapy to use the progestogen as either being the natural progesterone or the dihydrogestogen. And in that category of patients, that will lower their risk. Women should be counseled about the risk of breast cancer with hormone therapy, putting the data into perspective, with the risk similar to other modifiable risk factors such as 2 daily alcoholic beverages, obesity, and lack of physical activity. So observational evidence suggests that hormone therapy use does not further increase the risk of breast cancer in patients with a family history of breast cancer or after bilateral salpingo-oophorectomy for the BRCA1 and 2 variants. What about breast cancer survivors? Well, hormone therapy is certainly not advised for survivors of breast cancer. For survivors of breast cancer with the genitourinary syndrome of menopause, as I mentioned previously, vaginal estrogens or intravaginal dihydroepiandrosterone may be considered in consultation with the oncologist. So now I see a lot of breast cancer survivors in Durban. So some of the oncologists that I deal with will sometimes put their patients on vaginal estrogens without even sending them. But I also will meet resistance by some oncologists. But you need to discuss it with them so that the patient feels more reassured, and also to prevent the patient from getting different messages from their different caregivers. If you cannot use any vaginal estrogens in these patients with breast cancer survivors, please consider the use of vaginal moisturizers, which hydrate the vaginal mucosa, and the benefit is dependent more on regular usage than from a specific formula. When you look at vaginal lubricants, they only really provide comfort during the act of intercourse, with no direct benefit on the vaginal epithelium. They prevent irritation and potentially avoid those mucosal tears. And when you alleviate pain, then you improve all the domains of the sexual response cycle. But they do nothing to the background of the vagina, as opposed to, say, moisturizers, which may improve it.
Do you have a specific one that you use? Sorry, Steve, do you have a specific lubricant that you use? I know there are some ones that are available on the My Sexual Health website, but do you have anything else that we try?
I refer most of my patients to the My Sexual Health website, where they look at that. They've now got some silicone lubricants, which you can buy them off the website, just like how you'd buy something on Take-A-Lot, and it gets couriered to the patient. So you either have to use a water-based lubricant or a silicone-based lubricant. You must avoid the oil-based lubricants. And in terms of the moisturizers, it's usually, they all have a hyaluronic acid base. So, and even on the My Sexual Health website, they have a thing called Hydra. It's called Hydra, Hydra, which I've used in some of my patients. Yeah. But
Percy, what she said, Dr. Rudolph, is that we should use something called Assagai, which is the silicon-based, and people swear by it. And
I've got a patient this week who told me about Assagai. It's I think it is silicon-based.
It's a silicon-based, and it's all the rage here.
Yeah. But I think I have referred. I look on that website with my patients as well on My Sexual Health. There are quite a few options there, so I'll get a bit confused as to which one I recommend. Is there one that you specifically mentioned to patients?
Yeah, there's one that there's one. It's I don't know how to pronounce it well, but it's spelled PUJR. That range.
Yeah, pure.
Pure. Yeah. That's the one.
I've seen that one.
Used. Yeah.
Okay.
So that's the one I've used.
Good.
Quite a bit in
I
some
think it's quite easy to order it. So I'll just take the patients that website and I'll show it to them, and
I think it's a credible website, and it's better than them going to a sex shop and buying it, where they pay the earth for something that's really sometimes not based.
I think you can buy some of those in Discount. Assagai you pick up in Discount.
Yes.
Percy, just before we get sidetracked, there's a whole lot of questions. There's over 100 people logged on here, and one of the questions for Brandon Pillay: if one were to do serum FSH and estrogen levels, which time of the day in the cycle must it be pulled? You said during actual bleeding. Is that what you said?
So if the patient is still menstruating, there's no point doing it other than during the period, because these levels vary during a cycle. So for us to have a norm to compare it to a baseline, you have to have a specific time that you do it, and I do it during the period. So that's
okay. Another one says, anonymous says, in a patient who started hormonal therapy perimenopausally and presents now at 63 years, I suppose 10 years later, do you stop the hormonal therapy since she's above 60 years? Do I check if she did reach menopause? You've dealt with that. You say you don't have to stop menopause. Keep going.
You don't need to stop it, and certainly you don't need to do a blood test, because if you put her on hormone therapy, that means she was needing hormone therapy. And so if you want to have a trial of the hormone therapy, you have to give her about 2 to 3 months to see if she's symptomatic.
Okay.
That's how I would approach it.
Another one, anonymous. The two studies are talking about estrogen alone. Will combined estrogen and progesterone yield the same protection on cardiovascular disease?
Yes, if you use estrogen alone, you get better cardiovascular protection. When you use progesterone neutralizes some of the benefits of estrogen on the cardiovascular system. So we would never recommend anybody having a hysterectomy just to improve their hormone therapy use. But the patients who have had a hysterectomy for some other reason, and when they reach the menopause, then the hormone therapy is definitely much simpler and easier, because the breast cancer risk decreases, the cardiovascular protection increases. Progesterone definitely dilutes some of the beneficial effects of estrogen on the heart.
So progesterone is a poison. Moira Stein says, that's Professor Davies. You remember Professor Davies?
Yes, very much.
You always
so.
used to say that. Would you ever prescribe, she says, would you ever prescribe more menopausal therapy for women in the window of opportunity who are totally asymptomatic with low risk of cardiac disease or osteoporosis or colon cancer? Would that decision change if totally asymptomatic but high risk of osteoporosis, cardiac disease, or colon cancer?
That's a great question. So the reason why we have not put it into any of the guidelines yet, although I think we're getting close to that now, is the fact that the evidence on the cardiovascular protection for us to put it into a guideline has not reached a level of robustness that we can put it into the guideline yet. So how would you approach your patient who's asymptomatic, doesn't have this thing? You have to tell her that if she asks you what are the benefits, you say there are benefits as far as the cardiovascular system. And if by informed consent she agrees to take it, there's nothing wrong with that. But when we do a guideline, unfortunately, we're restricted by the fact that it needs to meet the criteria we put in before it gets into the guideline is very stringent. So we haven't reached that level yet. That's the reason why we haven't.
Yeah, and on that point, just for my own practical purposes, which one do you actually prefer to start off with? What do you actually start? I mean, where do you start with that? I mean, there's been multiple options.
Yeah, so
you discuss with the patient, or what is your preference?
Yeah, so in that now, I would, if you're looking at in terms of cardiac protection, both if she's asymptomatic in that category, whether you use oral or the transdermals will probably not vary. And so I give the patient the choice of what she would like. But I generally tend to use in those patients the transdermal options.
Okay.
And I use I tend to use it I'll either use a patch with dydrogestogen, or I'll use Femigel with the utrogestin.
Okay, no, that's a nice option. No, I like that too. All right, thanks. Do you want to finish these last questions, Pete?
All right.
Or do you want to get to the end of the talk?
All right, let's Percy, let's let you finish because there are lots of questions still.
Sure.
Perhaps you'd leave us some time.
I know there will be time. There will be time. There will be time for sure. So we've done that one. So what about the patients who have gynecological cancers? They commonly experience menopause because often the treatment involves bilateral salpingo-oophorectomy or may involve chemo and radiotherapy. And we know that hormone therapy effectively manages these symptoms. So what do we do? So if you take endometrial cancer, if it's early stage type 1, you may consider using menopausal hormone therapy. But women with a history of high-grade endometrial tumors, unfavorable histologies, and advanced endometrial cancer should consider non-hormonal treatments for menopausal symptoms. So it has to be individually based. With regard to ovarian cancers, the only ovarian cancer that you will be scared about using hormone therapy is the sex-cord stromal tumors. And if they have the serous and endometrioid histology. So you have to look at what type of ovarian cancer, what is the histology, and then depending on the symptoms. Whereas the squamous cervical, vulvar, and vaginal cancers, no problem with using hormonal therapy in those patients. The low-dose vaginal estrogen therapy can be considered as needed for treatment of vaginal dryness and dyspareunia for all types of gynae malignancies, even the endometrial cancers and even the ovarian cancers. Okay, this question was asked in some of the questions. What about the duration of use and whether we should use it? The safety profile of hormone therapy is most favorable when initiated in healthy women aged younger than 60 years or within 10 years. So initiation in patients older than 60 years requires careful consideration of individual benefits and risks. And long-term use of hormone therapy greater than 10 years needs an ongoing audit of benefits and risks. That's what I mean when you assess the patient yearly. There is no definite stop date in terms of age, but how do I mitigate the risk is I achieve that through lowering the dosages. So when my patients are over 60, etc., and they've been on hormone therapy 10, 12 years already, I reduce dosages. So I reduce dosages, and that allows me to use the therapy for a longer period of time and lessens my risk of complications. For example, we have low dose Formosan Conti if you want to give it orally, or we use the non-oral route of administrations. And you can reduce, even in the patches, you can reduce the dosages. So this is a topic on its own, and I'm not really going to spend time on it. This is on the androgens. But if you ever want to look at how you use androgens in this thing, let's go to this global consensus position statement on the use of testosterone for women, because it looked at the benefits and potential risks. It provided a clear guidance as to which women might benefit from it. And more importantly, they also identified symptoms, signs, and conditions where evidence does not support the prescribing of testosterone. So just to summarize what they said, the key messages: the only evidence-based indication for testosterone therapy is for the treatment of hyperactive sexual desire disorder. And there were no severe adverse events during physiological testosterone use. But remember that patients at high cardiometabolic risk were excluded from the study populations. A blood testosterone level should not really be used to diagnose this. And we haven't really established the safety of long-term testosterone therapy yet. But it's a complex topic and may warrant a discussion on its own. But if you want some guidance, go to this consensus statement. The one drug that's approved in terms of sexual dysfunction is tibolone. And basically, it's a drug that's got estrogenic, progestogenic, and androgenic effects. And the androgenic component has a positive effect on libido and sexual function. And so if you use testosterone in females, you'll be using it as an off-label product, whereas tibolone is an approved product for treatment in the menopause, and certainly can be used in patients who also complain of a lowered sexual desire. But not all my patients who've had lowered sexual desire have responded to tibolone. Some of them have had to use testosterone.
So why is that, Percy? Why do some not respond? Because I've got the same problem.
Yes,
I say, this will help you, madam. Yeah. And she says, no, you're wasting your time. I've tried it.
Yes, I've tried it, yeah. So that's because I think the androgenic component in the tibolone is probably not enough. And testosterone is more powerful. And generally, you will see an effect when you're using testosterone within about 2 weeks. And the maximal effect would be about 6 weeks. If you don't see that sort of effect, then you're dealing with other stuff. But it's very important when you're using androgenic supplements for your patients with lowered sexual desire to make sure that you've taken a very good history and excluded the other causes. In other words, this must be a patient where you think their lowered sexual desire is due to a lack of hormones. If it's caused by other factors, there's major marital discord, etc. You can use all the testosterone in the world. You're not going to make a difference. So I've certainly had patients who have used tibolone because it's an approved product, but not all my patients, and my experience is the same as yours. What about the category of premature menopause? This is when you get it under 40 years of age. You must confirm this diagnosis by history, examination, and appropriate investigation. Your treatment must take into account whether the patient still desires to conceive. I must stress this: the moment you make the diagnosis of premature ovarian insufficiency, there is no contraindication to treatment in this category of patients until approximately 51 years of age, in order to prevent the complications of lowered hormones. The type of hormone therapy must take into consideration the patient's medical history, look at your objectives of treatment. And they will require, this is a special category of patient who requires management in physical, psychological, and reproductive health. So you need a multidisciplinary approach. And if you're running menopause clinics, especially in academic centers, you should have a separate clinic for your premature ovarian insufficiency patients, not see them with your menopausal patients, to avoid aggravation of the emotional trauma. So I make a plea here: if you see a patient with premature menopause, please put them on hormone therapy. All those risks that we spoke about, breast cancer and thrombosis and all, don't really apply in this category of patient. All right, what about some new therapies, some new research? They've discovered some neurons in the hypothalamus called the kisspeptin neurons. And the neurokinin system was discovered about 6 years later. So they call them the candy neurons. They refer to kisspeptin, neurokinin B, and dimorphin. The important thing about this, when you have estrogen deficiency, you have an hypertrophy of this system in the postmenopausal hypothalamus. And it's been found that neurokinin B is a key mediator of hot flushes. So therefore, it was postulated that if we come up with a neurokinin antagonist, this should attenuate hot flushes without the need for estrogen exposure. So they've now advanced phase 3 trials. In fact, there's now a drug that's approved already by the FDA in 2023. Just to give you a summary of the success rates, hormone therapy, you get about an 80% reduction in symptoms. If you use the antidepressants, you get about a 40%. Cognitive behavioral therapy, about 40%. The herbal remedies are no better than placebo. And the placebo response in the treatment of menopausal symptoms is as high as 25%. So these antagonists, this NK3 antagonists, are almost as effective as hormone therapy and definitely superior to the non-hormonal strategies. There have been no serious adverse events reported so far. The one study reported a transaminase raise, so maybe we need to have some caution if the patient has liver disease. The good thing about these studies, these 3 trials, the 3 main trials, there were very similar results between the studies despite different methodological designs, different sponsors, and chemical compounds. And I feel that these compounds are likely to have a particular role for those patients with contraindications or an aversion to hormone therapy. And I'm referring specifically to our breast cancer survivors here. However, I must caution that none of the studies in the phase 3 studies used it in any breast cancer survivors. So that's only time will tell whether we can use them. There are some patients that you will not be able to use hormone therapy, either because they don't want to take it themselves or there's a definite contraindication. So you have to have some non-hormonal alternatives. If you ever want to see a good article on the non-hormonal alternatives, just go to the NAMS 2023 position statement, and you can download this for free. And it divides the non-hormonal therapies into what we call recommended and those that are not recommended. So in the recommended, it's a cognitive behavioral therapy, the selective serotonin reuptake inhibitors, the SNRIs, gabapentin, and oxybutynin, and then the new NK antagonist are the drugs that they've recommended. The ones that are not recommended.
Percy, sorry, can you just go back to your previous slide?
Yes,
yeah, that's one, yes. I'm surprised that oxybutynin is recommended because, yes. Steve's sitting next to me, and we, for many years together, did the female continence clinic, and I still do at Curtis Care Hospital. And many of the women complain bitterly that oxybutynin is really bad for their cognitive disturbance, particularly in older women, because of its side effects. So I'm surprised that NAM says, no, you can use this, and it's recommended.
Yes, they did. And I was surprised when I saw this, but when I looked into the article properly, they felt that it should only be used for short periods. So you need to use it like for, say, 3 to 4 months. Then the patient needs to go off it and look at some other alternative. So it's not like the SSRIs or something that you can use on a long-term basis. So I agree with you. I was surprised to see that, and certainly in our older papers, this was never recommended. This was a new one.
Okay, thank you.
So basically, just again, a practical question. So I know a lot of guys are using the SSRIs and SNRIs. Do you have a specific practical guide for that for people? I mean, there certainly be a role for it. I referred one of my patients on to someone who I felt needed this, but for those of us who want to just get something going immediately, what do you suggest?
I've used the Aeropax, even the original SSRIs, which are relatively cheap now. Prozac, I've used that, and I've certainly used, and in the SNRIs, I've used a lot of Effexor. So especially in my breast cancer survivors, I've used Effexor as one of the drugs that I've used. And how do I use the Effexor? I usually use it. One of the problems with Effexor, it can cause insomnia. So I make my patient take it around midday. And I usually use a combination of Effexor and gabapentin So the problem with gabapentin is that it causes drowsiness, also known as neurontin. And but you can titrate the dose. You can start off at a low dose and start increasing the dose if you're not getting effect. And it certainly cuts down the nighttime hot flushes and improves the sleep pattern. So I've usually used a combination of both the SNRIs and gabapentin from my experience.
Thanks, that's very useful.
Okay. Then, as I said, those were not recommended. Like if you take things like yoga and exercise, etc., those are very good for your general health. But what NAM says is that in their studies, they haven't found evidence enough that it works for hot flushes. So in conclusion, I would say that individualization is the key. You start with the lowest effective dose, estrogen only if there's no uterus. If they've got a uterus, you have to use an appropriate progestogen. So what I mean by this appropriate, let me just expand on this. So if you got a patient in whom bleeding disorders, they're having abnormal menses around the time of the perimenopause and menopause, that's the patient that will do very well with the noethistérone type of progestogen, because those progestogens do very well at cycle control. Whereas if the patient has a higher risk for breast cancer and you're worried about venous thromboembolism, then you must try to use a dihydrogestogen type or a utrogestin type of progestogen. So what I'm saying is you have to understand a little bit of hormones in order to choose the particular type of hormone therapy for your individual patient. It's just not whatever comes into your mind. The most appropriate length of time according to the indication, I said you must consider transdermal applications if at risk of venous thromboembolism. I would avoid compounded products without adequate trial data. And thank you. That's it. I'm prepared to answer questions.
Well, thank you so much, Percy. We've got a whole list of questions over here. Steve, would you like to kick off with the questions?
Look, I'll have my own question first. You know, we get a lot of patients who, well, not a lot, but who've been to these other doctors who would give these compounded products, natural products, you know, these integrative medicine people, and a lot of them, the patients do like them. Do you just allow the patient to continue on that? Are you deliberate in stopping those things? I mean, they might obviously come to you with another issue. I see a lot of pelvic floor urogyne patients on these things. Yeah. And if they're working, I tend to just, you know, not interfere with that. But what is your approach to these patients?
My approach is similar to yours. I would counsel them. I would say to them that there's no real evidence, you know, but if it's working for you and you prefer to take that. My problem is in these patients who use these compounded stuff and don't have any examinations, don't have the pap smears, don't have the prevented aspect. So the beauty of a menopause consultation is you're often seeing a patient who's well, who's relatively well. And you should use that opportunity to really practice preventative medicine, you know, do everything that you can optimize their health for. So my worry with a lot of these compounded products is they get it from pharmacies, etc., and there's no medical checkups that back it up, even at general practitioner level. So in the patient who's convinced that that is working for her, sometimes I don't force them to stop it. I advise them against it. What I specifically say is that I will not prescribe it. So what I say to the patient is, if you want to take that, that's fine, but I'm not going to prescribe it. I'm not going to sign my signature to that because I don't believe in the drug. But if you're happy with it and you think it's working for you, I'm fine with it. That's
okay, thank you. Another one, anonymous, says, is it worth calculating a patient's breast cancer risk with the IBIS calculator? I'm sure you know what that is. It's commonly used prior to starting them on hormonal therapy, especially with a positive family history.
Yes, I definitely do that. It's very much like the FRAX that we use for us in osteoporosis. So in the strong family histories, I take the thing down and I look at the risks, and it helps me to counsel the patient. So I definitely use it. But in general, a family history of breast cancer is not a contraindication, but it may be the type of patient that you got to look at discontinuing therapy after about 4 to 5 years. So just like I said to you, when I see patients with increased breast density, I flag them. Patients with a strong family history, I try to use non-hormonal therapies first for them. And only if the non-hormonal therapies do not work, then I move on to the hormone therapy. And the other benefit I have for that is what I told you, that if you have a gap between when they start menopause and become symptomatic and when you put them on hormone therapy, that decreases the recurrence of the occurrence of breast cancer. So,
Okay.
and also it selects out for me the patient that definitely deserves the hormone therapy. That's how
Okay,
I
next question. Right, here we go. Where does tibolone fit into the selection? In other words, we've mentioned about the libido. Is there any other particular indication or contraindication for tibolone or side effect?
I tend to use tibolone only in the patients over 50. And I seldom ever use it in the perimenopausal patient. I've also sometimes used it in the category of the premature ovarian insufficiency, because those patients also have a more severe androgen deficiency compared to the age-related patients, and they are usually younger patients, and the drop in libido tends to affect them more. But in my selection of using Livifem or tibolone, at least, I tend to use it in the patients after they've been about 51 years of age.
Okay, thank you.
And that's really for the patients with a low libido. Is that your only real indication for that?
For the low
Okay.
Yeah.
Because a lot of people do tend to use it almost as a first line, as a standard. So I like that answer. I understand that.
Of course, the only side effect of tibolone is poverty because it's not cheap.
Yeah, that's exactly the reason, Peter, where I would therefore not use it as my first line.
Yeah.
How much is it?
And it's about 5. I really don't know. You have to check out. Brandon Fellow says, Percy, please kindly share the link to SA menopausal guidelines.
Yeah.
Is there a link, or
Yes.
how do they get the menopausal guidelines?
It's available on in the SASOG website. It's available in the Better Gynae guidelines. It's like how you have the Better Op guidelines, or I could send it to Wendy, and she could send it to him.
Okay, very good. That's Brandon
I'll
Pillay.
email it to Wendy. Yeah, I'll email it to Wendy.
Now, Stavros, what does he say there, Steve?
Yeah, it's just asking about the patients with premature ovarian insufficiency. Do you go for a hormone therapy or do you go for oral contraceptive?
Okay, good question. If they're interested in fertility, then I tend to use hormone therapy for them, because there've been a few in the literature. There's been a few cases of a spontaneous return to fertility in 1 or 2 patients with premature ovarian insufficiency. So, but in the patient who's not interested in fertility, a lot of them prefer to be on the oral contraceptive rather than the hormone therapy, because that's what their age-related counterparts are using. So they don't feel at odd for that. So that's how I tend to choose it. Yeah.
Okay.
So the chances of fertility is extremely low. But if you put them on oral contraceptive, then it comes to 0. Whereas if you keep them on hormone therapy, there may be the odd chance. Yeah.
Okay. And oral contraceptive, do you mean Clara? Which one are you referring to?
I use one of the low doses. That, yeah, you can use Clara. You can use. I tend to use the Mercilon, the 20 microgram type of pills for these patients.
Okay.
Yeah.
There's been some criticism, says Anonymous, of the IBIS calculator in that they aimed at American women. In this country, we don't have American women. Can we safely use it in our population?
Yes, I still use it. I know what he is referring to, but in the absence of having anything else, it helps us, because for a lot of them we don't have. It's like the Frax we used. The Frax was done for people. Now only we've got a South African Frax set up, but previously we were using Frax to also give us a guideline. So I think it's still of use, because it also helps me, it reassures me. If I really find on the IBIS they fall into the very high risk, then I would counsel the patient to look for non-hormonal alternatives. You know, that's the type of stuff I take home, and at night I have to look at it on the calculator and then go back to the patient. You know, you can't do it that while you wouldn't with the patient. Yeah.
Okay. Steve, any room for SERMs in this SERMs, SERMS, Percy.
No, SERMs, yeah, it's selective estrogen receptor modulators. They will not work for as menopausal treatment because they actually, the side effect of SERMs is that they increase hot flushes.
Oh dear.
Yeah, so where SERMs comes in is that they are ideal for prevention of vertebral osteoporosis. So in the patients with just above 60, and they are also breast protective. So they're not an indication as a form of hormone therapy. Yeah.
Okay, excellent. Wow. That was a wonderful session, Siva. We thoroughly enjoyed it. I personally learned a lot. And there is maybe one last question there, if you wanted to just field it very quickly.
It says here, a patient with surgical menopause, oophorectomy, how early should one start on hormonal therapy? Immediately or wait for symptoms?
The surgical menopausal patients have a far more severe menopause. So often you have to start treatment almost straight away. Very few of my surgical menopause patients have waited.
Okay, now Steve's going to thank you. Thank you very much, Dr. Moodley.
Yeah, again, well, thanks so much. I mean, so many practical inputs, so many practical suggestions to us, and we really appreciate your time and effort that you've taken to prepare this talk and also to present it so clearly and so practically. So we really do appreciate that. And well, thanks again to Peter Young for, as always, being the energy behind these webinars, and thanks to Wendy for doing all the practical and the admin side of things. So we do appreciate that.
And thank you indeed to Steve.
Wow. What was next week's one again, Pete?
Yeah, next week when I mentioned, where's my piece of paper, Steve? Well,
I'm sure it'll come out quite soon. If you
hang on, here it is, Steve. Next week, what's this say? It says visit orthopedic. Hang on a minute. Now I'm in the wrong piece of paper, Steve. That's my X-ray of my knee.
Yeah.
I think we're gonna.
Okay, well,
Here we go. Okay, it's Dr. Henny Buerta. In fact, it's Professor Henny Buerta, and it's cervical cancer elimination. How can we achieve this goal? And it's sponsored by JDW Pathology. So another important talk. Hands-on, like you were, jobbing gynecologists always give the best talks, Percy, because we're the guys that have the questions in lived experience. In other words, real life. So another lived experience person, Professor Henny Buerta, cervical cancer elimination. How can we achieve this goal? And that's JDW Pathology. So a great big thank you from Cape Town. It's wonderful having everybody. Well over 100 people have logged on to hear you, Percy. So to test to your popularity. Until next time, maybe testosterone therapy, as you mentioned, that's something that needs to be visited. So, Steve?
Yeah, thanks so much. And thanks again to Abbott for the account sponsorship. And everyone safe home. And Pete, thanks for the use of your minibar tonight.
Oh, too kind. Okay, thanks.
Thank you.
Radio. Bye-bye.
Thank you, Wendy.
Safer.